Hi, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and host of the Dean's Chat podcast. One of my goals with the Dean's Chat podcast is to bring both leaders in the profession and to highlight organizations within our great profession. Tonight, we're going to be discussing the board certification process with the American Board of Podiatric Medicine, otherwise known as ABPM. My guests are Dr. Lee Rogers, the current president of ABPM, and Dr. Gina Painter, a past president of ABPM and the current exam committee chair. So welcome to Dean's Chat, Dr. Rogers and Dr. Painter.
Hey there.
Thank you.
Great to be here again.
There you go. You're no stranger to Dean's Chat, Lee. As you know, we go with first names. So if it's all right with you, let's go with Lee, Gina, and Jeff. How's that sound?
Definitely good.
Got it.
Sounds good. So Lee, I wanted to get started. I want to thank you for coming on again and making time. But B, before we get started, I want to thank you for all the outstanding opportunities you're giving our students when they go to San Antonio and clerk with your program.
That's honestly why I do it. You know, we really don't have a firm number on the number of students we take per month, and we also don't only take people that we would consider for residency. I mean, everybody comes here kind of looking to see if they're going to do a residency here, but you know, part of the University of Texas in San Antonio has always been that we give people that experience. They come here to get that experience. So we this is often the first place where people get their skin to skin surgery, their first skin to skin surgery, and the you know, if they weren't wearing a mask, you can see the gleaming smile that they had when they do it. So
well, I get the text from them saying, "Dr. Rogers, let me do this." So thank you.
Yeah, you're welcome.
So Gina, before we get talking about board certification, do you mind just sharing a little bit about your podiatric journey with our audience?
Sure. When I finished my degree in my residency program, I moved to Missouri, where I took my first job as an employed physician for another podiatrist, where I did some office work. And then I also was a doctor at Fort Leonard Wood, which was an Army facility where they did a lot of basic training work. So a lot of sports medicine type of escapades at that particular facility was always exciting. I then moved on to Montana, where I purchased my own practice about a year later. And there I joined a multi-specialty group and worked with them for approximately 12 years, where I sat on the executive committee and was chair of the executive committee and interim medical director at that facility before I decided to leave and join a 12-person orthopedic group, which then led to them selling themselves to the hospital. So then I became a hospital-based physician, where I worked for approximately 13 years before I left that facility and went to work for Montana VA system as medical director. So I'm primarily administration now.
And through all that busyness, you've been working with ABPM since 2003?
Yeah, I started as a volunteer. They called me and asked me to volunteer to provide the oral examination questions in Chicago years ago when they were still on a face-to-face basis. And from then I proceeded on to the written exam committee, and then exam committee sub-chair, and now exam committee chair, and served a stint and 2 terms as board of directors and then also president.
Wow, very good. So Lee, you're the current president of ABPM. How'd you get involved with ABPM?
Well, I was introduced to ABPM from one of the previous presidents, Mike Delacourt, who was my residency director. He wasn't president when he was my director, but he got me involved early and also on the exam committee. I think I joined the exam committee maybe 2011-ish or so. And then, you know, that's when we, you know, I know we're going to talk a little bit later about certificates of added qualification, but that's when we started saying like, hey, let's respond to what the profession really wants. And not only the board certification part of it, but how do you demonstrate your specific expertise in a part of podiatry that is maybe your passion?
Well, that makes sense. So when did you become the president?
It was 2 years ago. Yeah. So you can do 2 terms. Each term is a year, and then you're elected by the board of directors. So directors are elected by the diplomates, and then the board of directors elects its own officers.
Okay, very good. All right. Well, to set the stage for the discussion today, our profession has two certifying boards. The American Board of Podiatric Medicine is our medicine board, if you will, and the American Board of Foot and Ankle Surgery is our surgical board. So, good question for both of you. What is the significance of board certification in our profession? Lee.
Yeah, it used to be something that was voluntary, and people they were striving to become board certified, so that would set them apart from their colleagues and give patients and hospitals an indication that they had achieved a level of expertise above your standard licensure. Because if you look at the way that the licensure exams are written, people say, "Well, I don't have to keep taking all these exams," and it's a constant, lifelong process. And it's true; it is a lifelong process when you enter into any medical field. But not only as a doctor, but pretty much anything else you do as well. It's a constant, a constant investigation of whether or not you're staying up to date with the information in your specialty. But the licensing exam is one that's called minimal competency. It's an exam. That doesn't sound like you're very special, right? If you're minimally competent, but that's what I tell the residents when they pass the licensing exam. Congratulations, you're minimally competent. But that's what a state and a government is supposed to do. They're supposed to check and verify that you've reached a level of minimal competency, so that you're not going to hurt anybody when you're practicing. Board certification is a standard above that minimal competence. Now, the difficulty and the problem really is that no longer is board certification in really voluntary anymore. It's without board certification, you don't have. You can't get on insurance panels. That means that you can't get credentialed by insurance companies in order to bill them. Because I know you have a wide audience, Jeff. You got people that are just interested in podiatric medicine to doctors that are already in practice. But yeah, you can't get credentialed by insurance companies in order to bill them. Now Medicare doesn't mind. Medicare, you don't have to be board certified at all. But Blue Cross Blue Shield, pretty much all the big commercial payers that you hear about, they require board certification. Now they give you a certain window in order to get to that point, but most of them do. But the other major issue is getting hospital privileges. And we see this all the time where, podiatrists may not have realized what the bylaws said from their medical staff when they got their privileges at a hospital. And because those are a little different than your delineation of privileges, which is something you get every year, every 2 years, and you fill it out again. And it's are you still doing all these things? And are we going to give you these privileges? But your bylaws may say in the background that you don't read it every 2 years. They might say, "Oh, you have 5 years." That's very common, 5 years. But some of them give you 7 or 8 in order to get board certification, or your staff privileges are no longer renewed. Now that's different. That's different than being expelled or being thrown off the staff. Non-renewal, you really don't have a lot of recourse in that case, right? And so. People, maybe this would even be the last bit of advice I would give people, but let me get it at the beginning, which is when you get on staff at a hospital, read the bylaws, already in your mind, have this mental note of the timeline in which you have to comply with these rules. And that way there's nothing's a surprise. The last thing you want is a 1 month notice. That happens all the time. 1 month notice. Hey, by the way, you're not board certified, and we're not going to renew your privileges. It's devastating to people. So again, here's the main reasons nowadays to be able to bill insurance companies, commercial payers, who often require board certification, and then to stay on.
Yep. Did we lose Lee?
We might have lost you, Lee, for a minute here.
Yeah. So his 2 is to stay on hospital, credentialing and privileging, to stay onboarded at a hospital. So again, it's to allow yourself to bill as well as allow yourself to maintain your hospital privileges. And those are the main points for board certification. The other point is when you think about parity with board certification and allopathic and osteopathic medicine, those physicians have board certification. They use board certification to help delineate what they do, where they subspecialize, and it's very common language and it's a common activity. So it's something that we do to maintain our parity with our colleagues. So not just hospital credentialing and privileging, insurance, but it's also the language that our medical colleagues use. So if you aren't familiar with that, it is helpful.
That makes sense. And have you seen an evolution of board certification in the last 20 years?
Oh, yeah. Yeah. Overall, definitely. Podiatry has been very unique in the sense that we had a lot of benchmarks that were kind of structured as stepping stones going up to certification, whereas in medicine, in allopathic and osteopathic medicine, a lot of times once you complete your residency program, you're already considered eligible to sit for your board certification. So if you completed a residency in urology, when you graduate, you're eligible to sit for certification. In podiatry, you used to complete your residency, have to sit for a qualification exam, then submit cases, then sit for your certification exam before you can become certified.
So thank you, Gina. That's a great explanation. So Lee, you're back. And I wanted to ask you, how many diplomats do you have in ABPM now?
Yeah, I did. I just explained my change in scenery. We had technical difficulties, and I came in and got on Wi-Fi. So I'm outside, and it's 102, Jeff. So I'm burning up for you. But
you're taking one for the team.
Yeah, exactly. So we currently have the last number we have is 5863. So, but it's roughly 6,000 now diplomates at ABPM. We get about 350 to 360 a year, and those are mostly new graduates of residency programs, and so our trajectory's been pretty good, and I think most of that is just due to the fact that ABPM tries to promote a straightforward process for board certification, and also as many other allopathic boards, and we always say this. I don't even like to use the term allopathic. We are the only ones that use that term, allopathic, but maybe the osteopaths do. And you're in an osteopathic. Will they use that term too?
MDDO.
No. Yeah. So podiatrists always say this, but anyway, but if you look at the MD boards through ABMS, the American Board of American Board of Medical Specialties, they many of them you can get board certified pretty quickly out of residency, and so we just promote that as well because of the reasons that Gina and I just explained. The difficulty it is in actually trying to practice without being board certified. So, and Gina and I go to the ABMS meeting actually every year to see what's new with like maintenance and certification, how they're conducting their processes, how we can support. There are parts of our profession, and there are parts of medicine too, where people have some hardships. That's just life hardships, right? Whether family member gets sick or congratulations, you had a baby, you're starting your family, and we don't really we aren't as flexible as they are at AB, and that's what we've been trying to do. And so because of that, I think we've had some pretty good growth in ABPM. And so like we're over a third of the profession and just getting bigger every year.
So let's talk about that pathway to becoming board certified by ABPM. Where does it start? If you're a student, what should they be anticipating to get board certified?
So when you finish your residency program, that's when you can look at becoming board certified. And ABPM has streamlined it and mirrored what MDDO boards do, so that when you finish your residency program, you're considered board eligible. You no longer have to take a qualification exam. You no longer have to submit cases. You are considered board eligible. You've completed a 36-month residency program with or without the rear foot reconstructive added credential, and you can sit for the exam that fall if you choose. Some people will come right out of the gate and sit that first year. So if you finish your residency end of June, beginning of July, you can take your certification exam in October. If you want to wait a year, you can wait a year, but most people will come and do it right away because then they have it under their belt. Then they'll look towards what's their next step, and do they want to pursue something like a certificate of added qualification in a subspecialized area of podiatry.
Very good. And then if they do pursue a CAQ, is there a time frame for that too?
There are some entry requirements you have to meet based on the CAQ you're going to sit for. So, for example, for sports medicine, there's a couple of different entry pathways, just like there is in some of the subspecialty certifications, certificate out of qualifications, or focused practice that MDs and DOs do. So you could have completed a fellowship in sports medicine. You could demonstrate experience in sports medicine by submitting a letter that you're a team podiatrist, whether that's a local team, a state team, a national team, semi-professional, recreational, professional, or that you volunteer with something like Special Olympics, or maybe you work in the Department of Defense and you're a military podiatrist and you're seeing people who are highly active. You know, they're trained people. They are physically trained, and it is sports medicine that you are providing in that particular subgroup of patients. So there's different ways you can demonstrate your area of specialty, and then you can sit for the exam after that, after you've demonstrated it. So in some cases, there are some requirements because, again, we want it based on experience. And if this is where you're going to focus your practice, we want to be able to show that before you can sit for that certificate of added qualification.
So if a student takes the exam right out of residency and they pass, what does their next 5 years look like?
Lee, did you want to take that, or do you want to take that?
Yeah, it's so, you know, it's always better to take the exam earlier. And I'll tell you, it's just, we've looked at the pass rates, and the longer you get out of residency, it doesn't go down by much. You know, our pass rates, it varies from 82 to about 88% every year. If you look at MD board pass rates, all the ABMS boards, they're in the lowest is internal medicine, and that's also roughly 88%. But some are 98% pass rate for the board exams, like hepatology. So it doesn't vary by much, but it does. We notice that people who have been out longer have a lower pass rate for the exam. And then one of the issues that we've been looking at is just the impact that, you know, like I was saying before about if you had a baby, you know, you're just getting out, you're finally at a point where you're working and you're making money. But a lot of people decide that's when they want to start their family. I mean, they're at that right age, you know, or at the upper end of that age where they're saying, let's have a family now. And there's been some pretty good data out of ABMS. So these are the MD boards that have found that if a woman doesn't get board certified by 5 years out, then it's unlikely she'll ever get board certified. And these are things that we need to tackle as a profession and really say, like, how do we support people that are going through life and just doing life experiences, but still be able to verify their level of expertise so that they can have a job. I mean, it doesn't make any sense that, you know, just because you have a baby and you want to have a family, that doesn't mean you're not a good podiatrist or a good surgeon. So I think those are, if you ask me about our biggest improvements we're going to be making over the next 5 years or so, it's really going to be focused in those areas.
And I think also, you know, if you take it when you first get out of residency program and all of that information is fresh in your mind, you have a higher chance of passing it. Also, if you've taken the in-training exams as a resident, it improves your chance of passing the certification exam because you've had the experience of those particular types of questions, that particular type of case presentation. So you're familiar with it. The other thing is once you take it more than once, the chance of you passing continually drops. So if you're somebody who's taken it 3, 4, 5 times, chances are you're probably not going to pass it, which is unfortunate. Not everybody passes it. And I will correct Lee a little bit and say our pass rate typically for certification is about 88 to 94%. And for a certificate of added qualification, it's as low as 78% to high as 88%. So they are a little more difficult of an exam, again, to show an area of subspecialty experience and expertise.
That makes sense.
That's why I bring Gina. I always bring Gina because I bring her to correct me. So
not a problem.
No, I'm kidding.
Let's talk about the CAQs a little more. Certification of Added Qualification, a Certificate of Added Qualification, and the third one was the surgery. And it's no secret that has created a little bit of political controversy within our profession. Do you mind spending a few minutes talking about that?
Yeah, it has created political controversy, and I mean, you know me well enough, Jeff, that you know that we did that on purpose because we think that if you look at the way residencies are set up, there's a reason why there were two recognized specialty boards in the past, and that was because you could have done a residency in one thing or another, and now there isn't anymore. Now there's a standardized residency. And I often say single standardized residency. And I get people that correct me too. And they say, oh, well, there's the PMSR and then there's a PMSR RRA. But 98% of residencies are PMSR RRA. And I don't know why we still have just the regular PMSR residencies. It doesn't make a lot of sense to me. We got a surplus of residencies. Everything really should be standardized. And so that stands for Podiatric Medicine and Surgery Residency. That occurred pre-PMSR. PMSR is a designation. It's a designation for what the curriculum is in the residency. But when I finished in 2004, I graduated from Des Moines University, and in 2003 was when they started what was called the PM and S. Ampersand and they had a 24 or 36 month residency for that. And so everybody still did podiatric medicine and surgery. Pre that, you had a mishmash of various programs that you could have done. And it was almost, you graduated. When did you graduate?
I graduated in 91. I finished residency in 93, and I didn't even have an opportunity to take the ABPM or its predecessor's exam.
You did what? You did a PSR 24? What did you do? Yeah.
PSR 24.
So that, that stood for podiatric surgery residency, and 24 was the number of months you did. Right. And so, that's why it's really confusing. It's actually really confusing for our hospital partners, right. Even more so, because they look at it and hospitals actually nobody really is trying to deny you privileges. You don't go to a hospital and they're like, oh, how are we going to get this guy or this gal, and prevent them from having privileges. The medical staff professionals that work at these places, they just are saying, like, how do I guarantee that everybody's followed the rules, that the person's competent, that they're safe? And because our profession has evolved, and I say that because I think that we were at a higher level of where we were before, but because we've evolved so rapidly, these older terms are no longer in existence, and they're hard for people to find. So if you're a medical staff professional, you say, hey, Dr. Jensen came to apply to our hospital, but he has this residency that's called a Podiatric Surgery Residency 24. Does he deserve privileges at our hospital? And it's hard for you to explain that, and so so in that period of time, you could have done just a medicine residency, just a surgery residency, or some people said, hey, I'm going to do both. I'm going to do this residency and that one, and just put together like an a la carte menu of residencies. And it's much better the way we have it now. Everybody does PMSR, mostly with an RRA, rear foot and reconstructive ankle surgery. That's what that stands for. And so because of that, because we've standardized that process, there really is no need to have two boards anymore. There really isn't. And we have just, and I say we, I mean the profession, the two recognized certifying boards, we really need to come together and to just leave the profession with one board like the other specialties do. Radiology, for example, all of these other specialties, they have one board and they have one level in that board. Like, you don't graduate and get, you don't finish a a radiology residency, and then they say, okay, well, if you take the radiology boards, which is only one, but if you take these number of tests, you can read X-rays. If you take these other tests, you can read MRIs. That's part of your residency program, and so it's supposed to be encompassing in the board certification that you get. And so really that's been the political controversy that you refer to is rather unfortunate, just because I think it's pretty straightforward. I also think it's a way that acknowledges the growth of our education and training. And we're, I don't want to get, I get lots of nasty emails about things about trying to change things. I think they're for the better, but so I don't want to get too political on this, because I think you're doing a good job of trying to temper personalities and get everybody to the table to talk about where we go from here. And so I'll just say that when you evaluate that, and if you have two roads, one road is to be more like the ABMS boards that the hospitals are used to dealing with. They know the terminology. Just, I think, as Gina was, I caught a little bit of this whole when I was tuning out when I got lost signal, but it was about how we changed our name, or the name of what it is that you are in the first 5 years to board eligible. That's a term that all the MD boards use. And so when you go to a hospital and you say, and they ask, are you board certified? And your response is, no, I'm board eligible. They know what that means. And they say, okay, great. Board eligible, you're going to have privileges for 5 years. We know it takes a while to get your certification. And so that's just a way to give people a little bit of time to be able to do that. So, when you have these two roads, one road is being more like ABMS and being a little bit more inclusive, I believe. And another road is just continuing the same thing we're doing. We chose, we're going to try to improve what it is that we're doing.
And I think also it's looking at our profession, which has been fractured and splintered for a long time, having all those different residency programs, different boards, different this, different that, and trying to bring it all together. We're not a big profession, and we need to be more unified as a profession. If having a single board provides us another point of unity to help us build our profession and move it forward and continue to develop it, like develop good fellowships, develop additional training opportunities, develop, and maybe even at some point as scope changes across the country, maybe get a national definition of scope so that we can make it better for the people who come behind us. So although this may have caused controversy, we hope in the long run that it does provide unification of the profession and make it easier for the younger professionals coming after us. Because as a young professional coming out, I took my first exam when my son was 2 months old. And then I took my second one when I was pregnant with my daughter, and I got dual boarded. But maintaining dual board certification for the last 30 years almost is very costly, very time consuming. And it would have been much easier of a path to have one board to demonstrate my proficiency as opposed to having to do it with two.
Very good. Thank you. So Lee, let's say you're writing the script and you're proposing a pathway to one board. What does that look like over the next few years?
Well, we are doing that. That's the whole point of our public actions about this. But the just because you have one board doesn't mean that everybody's going to do everything that you're board certified in, right? So that's a major point of confusion for some people, right? So like, let's say you're an ophthalmologist, you did an ophthalmology residency, you get board certified in ophthalmology, and now that's a lot of different things that are in ophthalmology, and some ophthalmologists don't do surgery anymore. And that doesn't mean, you're still board certified. You can still maintain your certification even if you don't do surgery, but you were trained in it, right? And so that's the point of making sure that everybody has that same level of board certification that you're trained in. Now, that's why CAQs live above that. CAQs are, I'm really interested in sports medicine, or I'm really interested in diabetic limb salvage. And that's what I want to do. I want to demonstrate that expertise to a hospital that might be looking for somebody like me, or me, Jeff. You and I had these conversations because I'm trying to hire somebody here, and everybody knows what city I live in. I'm not supposed to advertise the professional basketball team that asked us to bring somebody there. But there, you can figure out which professional basketball team it is trying to find a team podiatrist, and our university is going to be providing that. So I have to advertise for this and try to recruit somebody for that. It's hard actually to find somebody with that sports medicine experience and also be verified that they can do what it is that they do. I spend a lot of time talking to people's fellowship directors, the other mentors of theirs. You actually connected me with a few people that you thought might be interested in this, and so having something that was a little bit more standardized, like the MDs do, you'd really be able to trust that process has already happened and do that. So, I mean, I think that what this looks like really is a single certification that you can take out of residency at a single level. There shouldn't be multiple tests that you need to get board certified in podiatry. You did your residency, podiatric medicine and surgery, and then you should be able to take a test, and maybe there'll be a case verification process with that, right? We still do that with our CAQ. We have, and orthopedics does that. Some other people do it. They do it differently than the way podiatry does it. I think their process is a little more fair than ours, but you should do that. Then you're certified. You're board certified in podiatric medicine and surgery. Literally, that's what it's called. That's where your residency was in, podiatric medicine and surgery. And then what really should happen is that you do extra training, and that extra training is tied to a certificate of added qualification. And while there are 90 fellowships in podiatry right now, it's kind of crazy to think about it, right? How many people do we graduate every year from BPM schools?
550.
Yeah, 550. So 90, that's like a sixth of all the people that are graduating. Either, I mean, those fellowships are available. I don't know if they're all filled, right? But there's 90 spots to go into afterwards. That's kind of crazy to think about it. But it also shows you where the mindset of some of the younger people are, that either they want it. And there's so many different reasons to want to do a fellowship. This is something we should just have a whole separate Dean's Chat about, honestly, where we get some fellowship directors in there and some people that are currently doing fellowship and say, why did I want to do it? What are the availabilities there? But some people say, oh, you know what? I didn't feel like I got enough experience in my residency. I think that's the weakest reason to do a fellowship, honestly. The best reasons is that you want to be mentored in some way, and you found a good director or a good place to go and be mentored. Our fellowship really focuses, it's obviously on diabetic limb salvage, but we focus on leadership and mentoring, because you can leave any fellowship and just get good training. But if you're not the person, I want to see our people leave and go start something somewhere. That's the biggest compliment to me, is if somebody leaves here, goes and starts something. If they get better than me, that's even a better compliment, And if they pass that on down the line, I know you think that too, in the way that you approach taking podiatry students. So, general certification, which is called in the MD boards, it's called primary certification. Above primary certification, you have either subspecialty certification or certificates of added qualification. They're called both things. And that should be tied to training. And really that's just a choice. Why deny people a choice to demonstrate their expertise and Gina, you have any different thoughts?
Well,
Gina's chomping at the bit here.
The main thing that I'm thinking of is, again, it comes back down to being primarily certified, because that gives you the ability to make a living and to find out what you really want to do in your podiatry career, because it may change. It will change over time. It may change based on the location where you end up practicing. Like I practiced in a small Montana town where you had to do a little bit of everything. There really wasn't very many people around that you can say, hey, go down the street. He specializes in that. Or maybe you end up working on an Army base like I did initially, where you're doing more sports medicine, or maybe you're in a bigger city where you can specialize in just surgical care. Everybody's path is going to be different, and you have to find what you like and what you're good at. And having primary certification gives you the ability to do that without having the stress over, oh my God, I'm not certified yet. What am I going to do? Because that is a big problem for a lot of people. Because if you don't meet your numbers or don't meet your diversity, it can be a barrier. And again, just like Lee said, for some women, you take time off to have a family and you lose momentum and you lose that time frame, and sometimes it escapes you. And it's unfortunate. We don't have a good pathway for reentry like MDs and DOs do into the board certification world. And it's something that we want to change and we want to see improve. And there are also programs for MDs and DOs across the country that if you took time off of your primary practice, that you can go and have a skills evaluation and then go back and get your hospital privileges. And the hospital is then certain that you are safe to practice. And we don't really have a good pathway for podiatrists to do that yet either. So it would be great as we move forward that we can create this for our profession and support the professionals coming after us.
Yeah, that's actually, I think that's a great point about your life changes over time. I don't know, Jeff, you ever thought you'd be a dean of a school, when you got out, and so you're, you may have an accident. I know people that have had a neck injury or arm injury, whatever. They can't do surgery anymore, but they, they're actually, still teaching or doing something else. Or actually now, I mean, look at what you can do online with online health visits and things like that. That doesn't take much to do that. You don't have to have a lot of dexterity for that. So the next design of how this works needs to accommodate people that are just getting out, and also the whole gamut of the profession. And when we say we, just like for you with schools, it's not only up to the board. I mean, the board does set its own policies and things like that. But there are certain things that boards can't do. There are certain things that schools can't do, right? There's certain things that residencies can't do. So this is where CPME comes in, and that's the Council on Podiatric Medical Education. They set the rules for, the rules are not as strong as they are for schools as they are for boards, of course, but they do set the framework on who is eligible for board certification. And so these are Gina is actually advocating. She's our liaison or representative on the new rewrite committee for the board language. And she's been advocating for some of these things to make sure there's at least we're strong about advocating for a reentry pathway. We accommodate as many people as possible. Again, not making things easier. I think that's wrong. You don't want to make anything easier, but you do want to make it fair and give people an opportunity to demonstrate their expertise and their skill. That, I think, if you do that, you're really you're really people focused. You're helping out people to be able to practice what they love to do.
Well said. So over the next few years, who knows what'll happen? Things may evolve. I know that from a school perspective, I get asked these questions all the time, and and new students come in, we play alphabet soup with the profession. We share with them all the different organizations. And right now, for the time being, we're recommending, of course, that they get double board certified. But time will tell. And I look forward to the future discussions on this topic in the profession for sure.
Awesome. Yeah, it's most people are able to get ABPM much earlier than ABFAS just with the case log requirements. So that's why our numbers are pretty high, I think, usually. But I agree with you, and all of my residents, I also am working toward them getting every certification available to them to be able to demonstrate what it is that they do, and we help our faculty out too, because it's good for a faculty perspective to make sure that your faculty are as notable as possible, and you lead an entire faculty, so you're. I have these meetings every year with people and say where you are on the track. How do we get you as quick as possible to the next level? And we're talking about like faculty levels, like assistant to associate to full professor. And that's just good for me to make sure that I've got a good group of faculty who qualify for all of these things. And board certification is certainly one of those. Gina, I think you can get the VA, you get a raise if you have more certification.
Yeah, actually, if you enter into a lot of hospital systems or VA systems where you're an employed podiatrist, a lot of times they will bring you in at a higher level of pay if you already are board certified. So it really behooves people to do that because it is more money in your pocket because you've already demonstrated that level of competency that's above just that basic entry level with licensure. So it's worth doing.
Yeah, it certainly isn't optional anymore. It's required. Is how you do it, right? Go ahead, Lee.
Let me give this good piece of advice to people that I see always. This always kind of gets people, and when it gets them, it's really sad because it harms a lot of young people when they first get out. All right, so here's the best piece of advice I can give you about when you first get your new job. You know, your first job when you get out. What are you thinking about? You're thinking about how first how I can, support my family, raise a family, all this kind of stuff. But you're also thinking about how do I get board certified at that time? And so when you get your first contract, make sure that you have, and I always tell people, make sure you have a lawyer review the contract, one that knows this kind of stuff. That $1,500 you spend is going to save you literally thousands and thousands of dollars, maybe even $100,000 if you ever make a transition from that job. You're not going to be there forever. What happens if the relationship, it may be nice now, but if it's not so nice, in 2 years from now, you want to have a way that you're going to be able to get. Now, here's one thing about board certification that needs to be in that contract, and it's that you have access to the patients you operated on, their records, after you leave that employment, right? Because if you don't, that you lost that time, you lost those records, and so you think, oh, I need to get X number of cases and all of that. Well, you can't even prove that you did surgery on somebody if you left under a dispute, which is sad, but I mean it happens, and you just lost it. So always, and people reach out to me a lot too, and I know they do but they're I counsel people a lot when they're looking at their first contract, and say, kind of give them a little bit of what's, everybody has a different idea of what's fair for pay, but I think what's fair from some other things, that's really needs to be put in there in the contract. Make sure you got it in.
I always tell residents when they're approaching their first job that not having an attorney review the legal agreement is, you wouldn't have the attorney do a foot surgery for you. So why are you reading legal contracts? You need an attorney to help pave the way and be the bad guy sometimes.
Yeah, well, actually, it's better when they're the bad guy, right? Because if you're in negotiations with somebody, things are great now, and you're trying to be friendly, and there are things you'd probably just let slide because you don't want to cause any problems when you first get there. But let your attorney be that bad guy, because they'll come in and they'll say, no, it's got to be this, this, and this, and the attorney will either negotiate with the whoever you're going to work with, if it's at a hospital, their attorney or something else. But you're right. I see it. It's mostly about $1,500. I don't know if you see a different number from people, but about $1,500 to get them to review this. But I had, just examples of just awful things that have happened to people when they left, when they tried to separate. And even if they try to separate amicably, right? You might be like, hey, I found something new. It's good for my family. Well, then somebody says, how are you going to pay for the tail on your malpractice insurance? And you're like, what are you talking about? Well, if you're going to a new place, you got to get a tail on your insurance. And that can be, we just hired somebody that was $24,000 that they had to pay out of pocket for a tail on their malpractice insurance. And that stuff you never even think about. So an attorney will think about it, especially one that knows healthcare and knows doctors, issues. These people, I do too. I know these attorneys all over the country. Somebody, they often reach out to me on forums and things like that and ask, hey, do you know anybody here or there? And I connect them because you just got to have that level of protection.
Yep. Great advice. Gina, any last words?
Well, I would just say if you're looking at podiatric medicine, it's a great profession to enter. It's been a great career. It's opened up a lot of opportunities for me, and I've practiced in different venues, and it's all been learning experience and beneficial. If you're a student, you got to put one foot in front of the other every day, complete your education, get your residency done. look to certification, get it done early if you can. And hopefully, if you can't, there may be some future pathway in the future. And then if you do find yourself really loving a niche in podiatry, don't be afraid to go for it, because you may really make a name for yourself, make a big difference in people's lives, in your community, in your profession. And then maybe you can even develop a new CAQ in the future. You never know. But I really hope that our profession unifies going forward, makes it better for our younger professionals coming out, because that's what we're all here for. And again, if you find somebody that could mentor you, that's helpful, or having a coach to a certain extent, and also just taking the chance and exploring things, because that's the best way we learn.
Absolutely. Well said. So Lee, I'm going to take you up on that idea to have a fellowship discussion. Let's get some fellowship directors and some docs that have done fellowships, because I've never heard anyone who's done a fellowship said, "Oh my gosh, I wish I wouldn't have done that." So I think that'd be a great discussion to have going forward.
Yeah, absolutely. And let me, I know you asked Gina for her last comment. Let me give one more last comment.
I was going to ask you one more last comment, Lee.
Yeah, that's I always have one more last comment. Here's mine, is that you're not going to like everything about every profession. You know, it doesn't matter where you go. There's going to be something that you don't like there, but you do have the power to change it and make a difference. You know, and people sometimes feel powerless in things like that. So if you don't like board certification, you don't like this, even if you don't like the way that you know, the something's being done in the school level, right? I mean, people have that opportunity to change it, but you have to take the opportunity, right? I see so many people that have the complaints, and I say, well, you got to get involved. And a profession that's as small as ours, it's actually pretty easy to get involved and to become a leader in the profession, and to make the change that you want to see by doing that. So so I would say that you do have a great opportunity, not only to practice what it is you like to practice, but to change things for the better by becoming a leader in the profession.
Absolutely. Well said. Well, we're running out of time. I want to thank both of you for carving out time. Lee, I'm sorry I kept you away from your journal club. My apologies to the residents and students. And I look forward to getting you both back on the Dean's Chat in the future. And thank you for all you do for the profession. It's not easy to lead. It's not easy to advocate on everybody's behalf, as you know, but I appreciate your efforts to do it. And so does everybody in the profession. So thank you.
Thank you for your time.
You're welcome. And
Thanks,
Lee,
Jeff.
you already have one of these, but I'm going to send you another one. And,
I need two. I can't just have one.
Gina, I'm going to send you Dean's Chat.
I want one.
I'll send you one.
Yeah.
And until we meet again, I want to thank all of our listeners, whether you're on Apple Podcasts or Spotify, please give us a 5-star rating. And if you're on YouTube, please become a subscriber. And until we meet next week, cheers, everyone.